So in this screencast, we'll talk about medication administration. So some EMS systems allow EMTs to administer medications under certain circumstances in certain situations following certain rules. And that would be either an assisted medication situation or those meds that are carried by EMS. Assisted medications are the patient's own prescribed medicines. And of course, they would have to be prescribed for that patient, not their spouse, not a family member, not a neighbor or a friend. It's got to be that patient's own prescribed meds. Their physician has determined that it is safe and in certain cases necessary that they take these meds. And so field folks, EMS members, would be able to assist that patient either with actually taking the medication or with the decision that it's okay to take it in this case. So it must be the patient's own meds, they must not be expired, and the directions for their use would be contained within standing orders that are contained within protocols that the medical director has authorized. Assisted meds that are allowed in scope of practice nationally include nitroglycerin, an EpiPen, or bronchodilators delivered via a metered dose inhaler. Then the other situation where the meds are actually carried by EMS. They're not prescribed for the patient, but EMS has those medications to deliver to a patient under certain circumstances. And those would include examples like aspirin or glucose paste. While technically it's probably a food, we consider it in terms of a medication. And then Narcan. And again, those directions are going to be contained within standing orders that are protocols approved by the medical director. So just because it's within the scope of practice of an EMT to deliver a medication, in our case nitroglycerin, it doesn't mean that that is allowed in our system because our medical director has not specifically authorized that. There are numerous routes of administration, and so we need to talk briefly about routes and how the route impacts the rate of absorption. And we'll go into those routes one at a time. Some medications can be delivered by several different routes, some only by one specific route, but really it comes down to a scope of practice situation, whereas a paramedic may have multiple options in terms of routes of administration for a specific medication. Often at the EMT level, there's only one route that fits within their scope that would be useful for that. So here's a whole bunch of routes, and there's probably a couple others, but the ones that matter to us and that we see in the field environment are intranasal, inhalation, topical, IM, IN, IO, and then oral, buccal, and sublingual. And we'll go through these one at a time. So intranasal is delivered into one of the nostrils or both nostrils one at a time, and the medication absorbs rapidly, very rapidly, through their nasal mucosa as long as the medication can get to their nasal mucosa. The rate of absorption there is quite rapid, not as fast as IV, but certainly fast enough to use in an emergency situation. And then runoff, of course, may be an issue. You can only really give a volume of 1 cc per nair, per nostril. And what happens is that this is delivered via an atomizer, which is similar to a fog nozzle that fits on the end of a syringe, and as the liquid medication is forced through that atomizer device, it turns it into tiny droplets. Rhinorrhea, which is a runny nose, may certainly be an issue because the nasal runoff, the snot, would be a barrier to absorption of that medication. Obviously, blood, bleeding from the nose would also be an issue. And Narcan is probably the prime example of an intranasal med that is given in the field setting. Paramedics are able to give some medication for seizure control as well as for pain control, but Narcan is the primary one that is given. And so the specific issue with Narcan is not just a runny nose, but it's also if that patient has snorted some cocaine, which would cause vasoconstriction So the blood vessels in the nasal mucosa would be constricted and would be less likely to absorb a medicine given intranasally. Inhalation is where a medication is broken into either tiny flakes or tiny droplets and is inhaled, and that's also rapidly absorbed through the pulmonary tissue, just not all pulmonary tissue, the pulmonary tissue that is distal toward the end of the pulmonary tree. So we're talking terminal bronchioles and alveoli. And so if a patient is dead spacing, meaning they're not ventilating all of that pulmonary tree, they're only ventilating, moving air through, say, the trachea and the main bronchi, then we can give all the medication we want via inhalation, but if they're not getting it to the terminal bronchioles and the alveoli, then no absorption is going to take place. And then patients who are taking medications by inhalation, these are typically bronchodilators, medications that dilate bronchioles. If those bronchioles are constricted significantly, then that's what the medication is for. But there's 3 ways to obstruct a bronchiole. You can clog it up with mucus. You can have enough inflammation that its passage narrows, the lumen of it narrows. And then you can also have some constriction. And all 3 of those are in play to one degree or another with our patients who are wheezing. All 3 of them. The trouble is you don't know which one of those 3 is the main culprit, and the bronchodilator is only dealing with bronchial constriction. But if they're so clogged with mucus or they're so inflamed, you won't be able to tell that. It's just that your medication will not have the effect that you're hoping for. So the main medicines that we give by inhalation are albuterol and ipratropium. And sometimes those are in a combination. Sometimes they're standalone. They come by many different trade names. But if the medication includes albuterol, we can give it by metered-dose inhaler under certain circumstances when it's indicated, as described in our protocol, and the same thing with ipratropium. Topical, not really a route that's used by EMTs. In some systems, paramedics use nitroglycerin that's given topically. The patients maybe have a medication patch or ointment that contains nitroglycerin, and those will typically be worn on their chest, although they can be worn almost anywhere. And so the only thing for us to remember about medication patches is that if you're trying to put an AED pad over the top of a med patch, you need to remove that med patch right quick before you place that AED pad. But generally, topical route is, while it's one of the routes, it really doesn't play into our world at the BLS EMS level. Pretty much the same with intramuscular, with the exception of EpiPen. But IM, or intramuscular, has a relatively slow absorption compared to, say, sublingual or IV or intranasal or inhalation. It's relatively slow, although still fast enough to do some good. The issue there is that you're injecting into a muscle, and if the circulation, the perfusion of that muscle is low, then the absorption of that medication will be low. And so in our setting, probably what we're talking about is an IM injection of epinephrine via an EpiPen. And by definition, that patient is experiencing anaphylactic shock, which can lead to localized tissue hypoperfusion. In other words, where you inject the epinephrine isn't getting enough circulation to circulate the epinephrine. So that may be problematic, but in many of those cases, that's your only route anyway. And as far as an EpiPen goes, that's the only route for an EpiPen, so you just have to do the best that you can in that situation. Just to be complete, there is a medication route called subcutaneous, or sub-Q, abbreviated SQ. And a long time ago, we used that for administration of epinephrine, and that has been replaced in most cases by IM. Sub-Q was even slower, and even had even more erratic absorption than IM, and most services have switched to IM. As far as our work on the fire district, really the IM route is not for EMR or EMT scope of practice, with the exception of assisted administration of an EpiPen. IV, again, outside the scope for EMRs or EMTs. The biggest problem with giving medicines via the IV route is getting the IV. Very sick patients are sometimes very difficult to establish an IV on, and so while it would be a very fast absorption, extremely fast, as fast as there is, the overall time to delivery and absorption is based on the initiation of the IV as well. An example that you may be familiar with would be a diabetic patient who needs IV glucose. And so, yes, the IV glucose will act faster, but there may be a delay in getting the IV in the first place. And so ultimately, some paramedics may make the decision that the very slow absorption rate of buccal administration, or even worse, oral administration, or IM administration of glucagon, for instance, as an alternative to glucose IV, they may decide that overall it's going to be faster to go with the slower absorption rate route because the initiation of the IV is so problematic. So again, not for us at the EMR or EMT level, but something that we work around and see since we are in an ALS system. Pretty much the same thing with intraosseous or IO. This has become very commonplace in cardiac arrest. In most cases, you can rapidly initiate the IO, whether that is done in a proximal tibia placement or in the humeral head, the upper arm. While the humeral head administration is lightning fast, the access and landmarking to find the right spot for that has been proven to be problematic. And plus the presence of that IO needle in the bone in the upper arm during a cardiac arrest is really just asking for it to be dislodged. So most of the time the tibial placement is the choice. Some of those tibial IO lines flow really rapidly, almost as rapidly as the humeral head, almost as rapidly as IV. It's certainly easy to access. It's certainly out of the way of the other things going on in the resuscitation. But some of them also flow pretty slow. And there is some evidence that they flow so slowly that it's better to have an IV, even if it takes you a little longer, or it's better to go for that humeral head. So as you work in our system around ALS players, they will be utilizing the IO route on cardiac arrest and maybe some other very critically ill patients. Just realize that that humeral head IO is problematic for them in terms of a relatively difficult landmark to find the right spot, and then securing it and having us not bump it is also a challenge. Oral medications many patients take every day, and they are absorbed slowly, relatively slowly, fairly slow in comparison to the other ones that we've talked about. Some medications have a coating that allow them to be time released. Others start dissolving as soon as they're ingested, but still, oral route is very slow. Plus, those medications that are delivered orally are dissolved in the stomach, and then that medicine must pass through the liver for metabolism before it's distributed, which even further slows things down and reduces somewhat the concentration of the medicine. In the field, however, we do use aspirin. We would like the patient to chew those up to make into smaller pieces that are more rapidly absorbed. But aspirin is the most common field medication that's delivered orally, and it's the one that we are involved with. Buccal, or buccal, some people say, or buccal, some people say. I'm still not sure what's right, but I'm going to say buccal. A pinch between the cheek and gum, basically. This is how chewing tobacco absorbs. It's how other things that are placed between the cheek and gum will absorb into the system. This is much, much faster absorption than oral. So when we are using glucose paste, we don't want the patient to swallow it. We want it to be between the cheek and gum until it absorbs. Plus, if we can go through the buccal route, then that's going to be faster and better because it doesn't have to go through the digestive system or deal with first pass metabolism through the liver. So this route is what we choose for glucose paste, and that's the only thing that we give this way, and it's a very common thing that we give. Sublingual is the area under the tongue. That's an extremely vascular area. Nitroglycerin tablets are typically given via the sublingual route. It's very rapid, almost as fast as IV, but there's nothing in the fire district protocols that utilizes the sublingual route. There's a whole bunch of terminology as well, so when you study pharmacology, you get into all of these various terms and characteristics of a medication. Its generic name, its trade name, its dose, its route, its indication, meaning what it should be used for, its contraindication, meaning situations where it should not be used, its action, meaning what it does to the body, the onset, meaning when that action starts, the peak, meaning when the blood level is at its highest, and the duration, meaning how long it lasts in the system, and then what side effects there might be and what adverse reactions there might be. And so side effects are something that occurs and we're not surprised, but we didn't want it. An example there would be nitroglycerin. Nitroglycerin very commonly gives the patient a transient but kind of intense headache that comes and goes. Well, the patient's having chest pain. That's why we're giving them the nitroglycerin. We're not trying to cause them head pain, but it's a very common side effect. It isn't harmful, it's just unpleasant. And so we don't need to be overly concerned about that because we expect it. It's a side effect of something that we expect but really weren't looking for. Whereas an adverse reaction is when they experience something that is harmful to them that we do not anticipate, and those are relatively rare. So I'm going to switch now to how we do business with medications. And in the top lid of our Red EMS pack, we have now placed the clipboard, and the clipboard contains the EMS notes form, and it also contains the medication guide. So all you have to remember about medication administration on the fire district is to find the guide and follow the guide. There's a lot of information on the guide. We don't need you to remember that information. We need you to remember where to find the guide and then be able to read and interpret that information. So here's the clipboard with EMS notes form on the top left, a cardiac arrest checklist, which is both for documentation as well as to make sure we don't forget anything. It's the command board for a cardiac arrest, if you will. And then the medication guide is shown there on the bottom right. That is a two-sided laminated document with pretty decent sized font, fairly easy to read, and we'll go through what it says for each of those medications as we talk about the meds here going forward. So aspirin's the first one we'll talk about. We carry 81 milligram tablets, and they are chewable. And we would very much like the patient to chew them, to break them into smaller bits, help them absorb more rapidly. Here's the information from the medication guide for aspirin. And so an EMT can administer one full dose, which is 4 of our 81 milligram chewable tablets to a total of 324 milligrams. One full dose of aspirin to a patient with suspected myocardial infarction. As long as the answer to every single one of these questions is no. They cannot have an allergy to aspirin. They cannot have taken a full 324 milligram dose in the last 24 hours. They cannot have any ripping or tearing chest pain or a history of an aortic aneurysm. We do not want to give aspirin to someone who may have a dissecting aortic aneurysm. That pain is very reliably described differently than myocardial infarction pain. When the patient says it feels like someone's ripping a hole in my chest or there's someone tearing me up with a knife, that's much more indicative of an aortic aneurysm. It isn't always an aortic aneurysm, but if they give you that sort of description of their pain, you need to back off with the aspirin. The potential detrimental effects of giving the aspirin far outweigh the potential benefits in that scenario. The patient must not have any signs of GI bleeding, no bloody stools, no tarry stools, no coffee grounds emesis, no bloody emesis, no signs of GI bleeding. Now, they can have a history of ulcers, They can have a history of GI bleed. They just can't be having an ulcer that's bleeding or a GI bleed right now. And then there cannot be any signs of a stroke. And so this one's a little difficult because the signs of a stroke that we're going to have to stick with are the Cincinnati Pre-Hospital Stroke Scale signs of a stroke. Cincinnati Pre-Hospital Stroke Scale signs of a stroke include slurred speech, facial droop, and one-sided weakness. And so the Cincinnati Pre-Hospital Stroke Scale is pretty good at catching strokes of a certain type, but really bad at catching strokes of a different type. And so if you're suspecting stroke, you want to hold off on the aspirin. Again, the potential benefit is far outweighed by the potential detrimental effect if that patient is having a hemorrhagic stroke. Aspirin prevents further clots from forming. It prevents clots. It does not bust up clots, but it prevents clots. A person who's having GI bleeding would need some clots. A person who's having a hemorrhagic stroke would need some clots. And we don't want to take out their ability to clot by giving an aspirin, just in case we might be able to prevent further clots or adding on to the one that already formed. So aspirin, while it seems fairly benign, and people buy it over the counter and they have it in their medicine cabinet, and it's no big deal, and in some cases the 911 operators tell them to take it, aspirin has contraindications. There's 5 of them. And we don't need you to remember those 5. We need you to remember to look up those 5. And the patient must not have any of those situations. They must answer no to all 5 of those. If they do, then go ahead and give them the aspirin. Narcan's the next medication that we'll talk about. We carry it in a Narcan kit. You can see the box with the syringe, preloaded syringe. Right next to it is the atomizer device, the MAD, mucosal atomizer device, carried in a hard plastic case, which gives you the dose, and then also some common opiate or opioid medications are listed on a list there. That's certainly not an exhaustive list. And remember that those are medications that are listed there. Certainly heroin's high up on the list as well. So Narcan can be administered by an EMR or an EMT, and they may administer 0.5 milligrams, which is half a cc, of Narcan intranasally if all of the following conditions are present. Now, that is a 2 milligram preloaded syringe. So in theory, a person could give 4 different doses of Narcan from what we carry. But all the following conditions need to be present. The patient must be breathing too slowly to maintain a normal pulse ox reading and is therefore requiring us to ventilate them and oxygenate them, and we've been doing that for more than 2 minutes. There also must be evidence to support an opioid or opiate use. Maybe there's visual evidence of a syringe or a bystander account, but in every case there needs to be a small pupil size. People that are under the influence of opiates and opioids to the extent that it's causing them to have ventilation problems should have very small pupils. If your patient does not have very small pupils, they don't fit the criteria for us to administer Narcan. Remember, these are our rules for Narcan. Police department may have different rules. Family and friends may have different rules. That doesn't matter. What matters is our rules are this. They are still needing you to ventilate them, and you've been trying for 2 minutes to ventilate and oxygenate them, and they're not waking up to the point where they can maintain their own ventilation, and they've got small pupil size, and it's been 5 minutes since the last dose of Narcan was given by EMS personnel. Now, what happens more frequently these days, at least in our system, is that Narcan's already been given by somebody else when we arrive. Sometimes that's law enforcement. Very frequently, it's family and friends. And so if the Narcan's already in, it doesn't work instantly. It takes 2, 3, 4 minutes to work, and if it's given intranasally, we already talked about all the problems with absorption there. It may have been that some of it went down their throat and they swallowed it, and it's now an oral dose of Narcan, which isn't a thing. It doesn't work that way. It could be that they have a very runny nose, or nasal mucosa are vasoconstricted from cocaine use or something, and so it may be that the Narcan just doesn't soak in right when you think it's going to. It's not an instant thing, and there's a lot of variables at play. So our plan is they've got to need you to ventilate them, and you've been ventilating them for a couple of minutes and they're not coming around. You're still having to ventilate them. They've got tiny pupils and they haven't had any Narcan for at least 4 or 5 minutes. Then you can administer 0.5 milligrams, which is 0.5 cc's, which is 1/4 of the syringe in that preloaded Narcan box that's in the kit. 1/4 of that. So the problem here is that you have to get a good mist out of that mucosal atomizer device, to get a good mist out of that nozzle, you have to push pretty hard. But then you have to stop pretty quickly. And the best way to do that is to put your thumb or another finger or something up on that syringe as a stop. So you can push rapidly with one hand and you run into a stop, your finger from the other hand. Bronchodilators by meter dose inhaler are allowed in scope of practice as well as our protocols. And there seem to be many different trade names and variations. We put a few of these up here. But the bottom line is the medication's got to include albuterol. It could include just ipratropium, but very frequently these days it's an albuterol ipratropium mix. But it could be that they have two different inhalers, one with albuterol and one with Atrovent, which is ipratropium. But very commonly now we're seeing Duoneb or Combivent, which are combinations of albuterol and ipratropium. These are bronchodilators. Now remember that the patient also has an inhaler with a steroid in it in many cases. And those are not going to be helpful in the emergent situation. Those are not within our scope of practice to administer. So that's why we're saying you need to make sure it's got albuterol in it or ipratropium. And albuterol is what we're looking for. If it doesn't have that in the inhaler, there isn't going to be any short-term benefit, and that's what we're looking for, is short-term benefit. Many of these patients that are COPDers will take a steroid by inhalation, by a puffer, by their inhaler. They'll take a steroid every day, and that's a maintenance dose. They take that at the same time every day, whether they're wheezy and chest tight and they feel like they're having a problem or not. They take it all the time. It's not going to do any good as a rescue inhaler, which is what we're trying to get done in this situation. So an EMT may assist the patient with administration of their prescribed bronchodilator via MDI, which they'll call an inhaler or a puffer, if all of the following conditions are present. The MDI must be prescribed for the patient, not expired, and it contains albuterol or ipratropium. And they have to need it. The patient has to have wheezes that we can auscultate with a stethoscope, or we believe that the patient has severely obstructed bronchioles. Remember that the tighter that patient's bronchioles get, the quieter the wheezes are. Loud wheezes mean that there's air moving. Quiet wheezes means there's not much air moving. Is there a chance that they could have very quiet, faint wheezes and we could still get some bronchodilator down to where the bronchioles, down to the bronchioles? It's possible. But remember, there's no magic solution for these. And so that's why these rules are in place. Probably isn't going to cause a problem. Probably the patient's heart rate is up some because they're hypoxic. So if we can get rid of some of the hypoxia, then we can get rid of some of the elevated heart rate. That's the only real side effect that people talk about. And then remember, assist the patient doesn't necessarily mean you have to hold it to their mouth and squeeze it, because they need to time it. They need to time the activation of the inhaler with a breath. And that's really hard for you to do for someone. So assisting in this case is more about saying, yes, you should take it, or no, you shouldn't take it, rather than actually giving it to them. Glucose paste is pretty easy to talk about. Again, technically it's probably a food, but we need to look at it like it's a medication. Just a pinch between the cheek and gum. How you get that pinch in there doesn't matter. I've had decent success with just squirting it in with a tube. Some people like to use a tongue depressor or maybe an oral airway as a, kind of a spoon to avoid being bitten. Comes in different flavors. They all say they're delightful. I think they're all disgusting. Not many patients love these. They're not carrying these around for a snack. They're carrying these around for when they get in trouble. Some patients will have these, but we have them in the EMS pack. This is one of those medicines that we carry and we can give under certain circumstances. And here are those circumstances. An EMT may administer one or more entire tubes of glucose paste. So the dose is a whole tube, just not all at once. A little pinch on one side, a little pinch on the other side. If you try to dump that whole tube in there, they'll drool it out or swallow it, neither of which is appropriate. And we are going to intervene when the patient's measured glucose is below 60, or in the case of a glucometer malfunction or something else, if you think they're hypoglycemic, give them glucose. If you're on the fence between whether they're hypoglycemic or hyperglycemic, and they're unconscious or they're in deep trouble, we should err on the side of giving the glucose. Now, in terms of consciousness, that's kind of difficult, and so I probably misstepped a little bit there when I said unconscious. We don't really want to put anything in the mouth of an unconscious patient. So, that's kind of a variable sort of thing. Are they alert? Well, yeah, no problem with a pinch between the cheek and gum. If they're responsive to your voice or responsive to pain, it's probably okay, because that's what this stuff's made for. Remember, and we're not putting a large enough volume in there to cause a huge problem. We're not putting the whole tube in there. We're putting just a little bit of a tube. I would say it will probably, if you were able to give a quarter of the tube on one side of the mouth and a quarter of the tube on the other, it'll probably take you several minutes to give this tube and have it absorbed, and then it will take several more minutes, like 10 or 15 minutes, for the patient to come around. This medication is given buccally. It's absorbed fairly rapidly, but not instantaneously. It's going to take a while for him to come around. So these are judgment calls in terms of, is the patient able to swallow and maintain their own airway? So in a case where you're thinking about using a nasal airway, or you're needing to use a jaw thrust to keep their airway open, they aren't able to maintain their own airway. By definition, you got to put the glucose paste away and wait for paramedics to start an IV. So it's a judgment call. It's critical thinking, which is a lot of what we do in EMS, and particularly with medications. EpiPen's pretty straightforward. It's got to be theirs. It's got to be not expired. And there are two sizes. There's like the adult version and the pediatric version. Whatever version they have is the version you use. It's got an auto injector, so it's a relatively spring-loaded automatic device. You press it firmly into their thigh is where we like to give it. I guess you could use an upper arm, but you're trying to put this needle into muscle, and you press firmly and it auto injects it. It injects the needle, it withdraws it, it injects the medication, and you just got to hold it into the muscle firmly and hold it there until you believe the medicine has been injected, which is just a few seconds. It's a very rapid sort of thing. You can go through clothing. You don't need to have bare skin. If you can get to bare skin, that's better. But in this sort of an emergent situation, you believe this patient has a life-threatening anaphylactic reaction. They're going to die if you don't do this. And so we're not going to take the time to get to bare skin on the thigh. We can just go right through. Again, it's got to be prescribed for the patient. It's got to be still valid, not expired. And they've got to have signs and symptoms of an anaphylactic reaction, which is not just that they were stung by a bee and they have an allergy to bee stings. They need to show some symptoms. They don't have to have all of these symptoms, but the trigger for us would be if they're having difficulty in swallowing, or if they have stridor, which is a high-pitched sound that is loudest when you listen over their throat with the stethoscope. It's not loudest when you listen over their chest. Difficulty breathing, which may or may not include wheezing, or if they have hives. Most of these patients that have allergic reactions and have been prescribed an EpiPen will be healthy enough to withstand the side effects of the epinephrine. And again, the epinephrine can be life-saving. So we'll talk briefly here about Epi versus Benadryl, or Epi plus or minus Benadryl. So epinephrine goes to the allergic reaction and stops it. It stops the chain reaction of events. It also helps with some of the symptoms. Benadryl simply deals with the symptoms. It does not stop the reaction. When a patient has an anaphylactic reaction, they have a large dump of histamine. Benadryl is an antihistamine. So Benadryl soaks up the results of the reaction, but it doesn't stop the reaction. An analogy that I've used a couple of times that may or may not help is that it's like at a fire, you need to put out the fire and then get rid of the smoke. Epi puts out the fire. The fire is the chain reaction that's occurring. Benadryl just pushes smoke out of the house. And as you know, we don't necessarily want to ventilate until we got the fire out. So the Benadryl makes them feel better. They should be a little less anxious, maybe even sleepy. It's getting rid of the histamine. And as long as the reaction's already stopped, or the reaction wasn't horribly severe, then Benadryl is okay. But when in doubt, when the patient has difficulty swallowing, or stridor, or extreme difficulty breathing, or hives, give them the EpiPen, and then just move on. It will be potentially life-saving for them. All right, so I want to wind this up talking about oxygen and nitroglycerin. And while oxygen is technically a medication, we don't really think of it as that, but I wanted to take this opportunity to run past the oxygen protocol one more time. And remember, all you need to do is get their pulse oximetry. You don't need to remember what's on this card. Just remember where to find this card. So you get their pulse ox reading, and if they don't have lung disease and their O2 saturation is 94% or higher, they don't need any oxygen physiologically. Emotionally, psychologically, they may benefit from some. Remember, 2 or 3 liters never hurt anybody with a nasal cannula. So if you think that's going to help them psychologically, that's fine. But physiologically, they're not demonstrating a need for oxygen if they're 94 or higher. If they're in the low 90s, 90 to 93, a cannula at a couple liters would be great. If they're less than 90 and they have no lung disease, then it's time to go with a non-rebreather. Anybody that has decreased level of consciousness gets a non-rebreather regardless of their SAT. And then kind of a general rule of thumb, if you put 2 liters on a patient for 2 minutes, you ought to get 2 points on pulse ox. 2 or 3 liters for 2 or 3 minutes should get you 2 or 3 points. If you don't get that 2 or 3 point bump in their pulse oximetry after 2 or 3 minutes on 2 or 3 liters, it's probably a ventilation problem in addition to an oxygenation problem. So keep doing the oxygen and then work on ventilation. Now, that's for patients with without known lung disease. Right there at the top in big yellow. I just need to read the words. Patients without known lung disease. This side is for patients with known lung disease. It's 2 sides of the same card, and it's attached to your pulse oximeter. These are the rules for patients with known lung disease, COPD. We'll allow them to have a little bit lower normal. So if they're in the 90s, they don't need any oxygen. If they're already on some, leave them on whatever they wear all the time. If you think it will help psychologically, a couple liters is fine. Even down to 86, 2 liters is all they're going to need anyway. Once they get to 85 and below, we bump that up to 4. And if they're at 80 or below, they need a non-rebreather mask, even though they have the lung disease. And again, if they have decreased level of consciousness, if they're not alert, if they're only responsive to voice or pain, they need a non-rebreather. Now, this is all predicated on your pulse ox working. But pulse oxes run on batteries, and battery-powered devices work fine at truck checks, work fine on non-critical patients, but they somehow know when you really need them, and they tend to not work. So we got to have a backup plan for our battery-powered device if it doesn't work. If your pulse ox won't give you an accurate reading, either it won't come on at all, or when you compare the patient's actual pulse to the blinking indicator on the pulse ox, they don't match. If you can't get an accurate pulse oximetry reading, then just go with the default O2, which is 4 liters with a cannula. Unless that patient's cyanotic, then use a non-rebreather. Unless that patient's got altered mental status, then use a non-rebreather. Or if in your best clinical judgment, something just doesn't seem right, and you believe your patient is sicker than the numbers that you were expecting, then you can use a non-rebreather. We just simply don't need to put non-rebreathers on every patient all the time. We need to use data and some critical thinking and use some judgment. But if the little voice in your head says, this guy's really sick and I think he needs a non-rebreather, then put a non-rebreather on him. So the oxygen protocol is described on a card connected to the pulse oximeter. But if the pulse oximeter doesn't work, or you just really don't think it's the right thing, then there's still room for you to use a non-rebreather. And the last thing is nitroglycerin. So nitro is allowed in scope of practice of EMTs, but it's not allowed by our protocols. The patient can have all the nitro they want, and if they think they ought to take it, then they ought to take it, but we're not going to get involved one way or the other. There's pros and cons on both sides. Briefly, the issue is that they could be experiencing an event, a cardiac event that will make them very low on preload or preload dependent, and then nitroglycerin drops preload, and then they get in trouble. So nitro probably never saved anybody, and it can cause some side effects. So we should be very conservative, very cautious with nitro, and as a matter of fact, we should just leave nitro alone. And if the patient insists on taking it, that's between them and their doc, but it's not a magic pill that's going to save in almost any case. All right, so summary, very short, simple summary to what's been a fairly long lesson. We talked about routes, we talked about indications, contraindications, all kinds of terms. We talked about the various medicines, but here's the bottom line, here's the take home. If you can remember where to find the medication card, then all you got to do is use the medication card. The medication card is found in the clipboard, which is now supposed to be in the top outside lid pocket of the EMS pack. Easy to get to. And you should get in there quite often to get the EMS notes form out, so you should see that med card all the time. Very important that you check your EMS pack at truck checks in all cases, but particularly make sure you've got that med card in there, because you're relying on that quite a lot. If for some reason you get into a bind and you don't have a med card and you really think you need to administer the medication, then you can contact the responding medic unit directly on the radio, have them call you on your phone. You can call the duty chief. We have cards, we know the cards. But remember where to find the card, and then use the card. Because medication administration can be risky. It can also be a very valuable tool that we use for our patients.